All right, so you mentioned you're doing Y90, you're doing TACE, you're doing hispasonic. So in terms of ablation in the liver, why microwave instead of cryo or RFA?
Yeah, so I was always taught don't do cryo in the liver. Theoretical, cryo shock. I know some cowboys out there who maybe have experience with it. That's not me. I think between microwave and RFA, I think there's a lot of advantages to microwave. One of the things is kind of the heat sink. One of them is, you can probably do it a lot quicker as well. I think kind of those are kind of the main factors. And I think when it comes to margins, I think it's a little bit easier with microwave to take out just a little bit beyond what you need. I think that, generally we're taught 5 millimeters or so. I try to go a little bit more than that, but, I think with microwave, you have a little bit more power as well, in terms of really, we talk about this all the time, how the outcomes of patients who get transplanted with no liver disease tend to be, a lot better. So if you really want to make sure, I have a phrase. It's very scientific, by the way. It's dead, right? If you really want, dead, as I say, like really, no viable kind of tumor cells, you really want to make sure, I think, that you get margins, and I think microwave is just a little bit better at that.
Right. Yeah. I'm going to want to go through a bit of detail later regarding your technique and how you ensure you're fully treating these lesions. But for a second, I'd like to talk about how you get these patients in the door. Who makes the decisions in terms of who's going to be treating these patients and with what at Columbia?
Yeah. So, in terms of how we get patients, a lot of it is driven by tumor boards. And I'm sure, I think, Mike, I've heard you talk about this before. It's kind of all across the country. Like, you have to have a tumor board in some capacity, right? We actually have two for the liver. We have basically kind of a general liver tumor board where we'll talk about some tumors, we'll talk about biliary stuff, we'll talk about, thrombus, tips, etc. And then there's another one which is specific for kind of HCC and liver tumors. So it's, very similar to any tumor board. It's kind of, we have our surgeons, we have our IRs, we have our hepatologists, we have our oncologists. And, a lot of it is kind of driven by, everything is individualized depending on the patient, depending on the labs, depending on where the location is. We'll all discuss it. And, I like to think that we actually have a pretty collegial kind of environment at Columbia where the surgeons, obviously, listen, surgeons everywhere are surgeons. They're going to want to cut everything out. But, there are a lot of studies that, and I think even in the NCCN guidelines, basically kind of the equivalency of ablation and surgery with a lot less kind of, recovery time and side effect profiles. So, based on that, and based on kind of really a lot of our experience with working with kind of the surgeons and everybody at Tumor Board, there's been quite a bit of trust that's been built up. So, it's one of those things where when we suggest something, a lot of times I'll actually say like, hey, this is not a great candidate for ablation or a Y90. And, that kind of, I think that goes a long way because the surgeons and the hepatologists and the oncologists, if you're kind of straightforward with them and honest, like, okay, look, this is what we can do, this is safe, and this is really kind of what we shouldn't do, I think they respect you a lot more. And, and I think it's like, they're like, okay, this person knows their stuff. They're not going to do anything dangerous. And they know what to do and what not to do.
Right. Yeah. And one of the unique things about liver cancer, both primary and metastatic, is that compared to other cancers, there really seems to be a lot of room for everybody. There's plenty of opportunity for systemic therapy, for radiation therapy, for surgery, and for everything that we offer. And nobody's really getting left out, and there's plenty of work for everyone.
Yeah, exactly. And, it's one of those things also where one of the nice things that we have at Columbia is we've gotten to a point, like, I don't want to say like it was always like this, but we've gotten to a point where there's a little bit more trust. So for certain patients, we may try certain things like, for example, systemic plus Y90 or ablation, and then we'll go on systemic, or a little bit of systemic to try and shrink down the tumor a little bit, and then we'll hit them with ablation or surgery. So we've gotten to the point where, for certain, and this, Mike, not every patient reads a textbook, right? Like, you have these criteria and you have these ideas in your head of exactly what we should do, but a lot of times the patients, they don't fit this criteria. So it's like, well, what do you do? You still want to help the patient, you still want to do the right thing, but you're kind of approaching it from a team approach. So it's like, okay, let's see what we can do safely. You hit it with your thing, I'll hit it with my thing, and let's see if we can kind of help this patient from both ends.
Yeah, man, a lot of these can be really challenging, especially like the ones you said that don't really follow the textbook.
Yeah, definitely. And that's, listen, for better or for worse, obviously we don't want to see the numbers go up for HCC and liver tumors, but, anecdotally speaking, like we've gotten very, very busy over the last few years, and, I would imagine it's going to keep going up. But like you said, it's a challenge, but it also makes it kind of, it's kind of interesting, in that it is a challenge, but it's a challenge that, every time we go to tumor board, we're like, all right, how are we going to conquer this one? How are we going to help this patient? And, the best thing is like, look, ultimately at the end of the day, like all we're doing in medicine is we're trying to give people time as much as possible. And look, we're all going to die one day, you, me, every single person. But it's one of those things where we also want to make sure that patients have kind of a good quality of life, And if you can eliminate disease burden and get people to a place where their quality of life is a little bit better, in my book, that's a win,
Absolutely. And, it's important to know you're not necessarily going to completely cure everyone.
And I think that's something that we struggle with in IR, and because maybe we're just trained to be like, okay, there's something like it's a task, like we've got to accomplish it, and like we've got to cure this disease, and obviously that's always the goal. But if we just think about it from almost like a patient-centric approach, right? Like that's obviously super important, and I'm not saying not to, but what's also important too is, in some cases, if you can't get cure, at least if you're preventing progression, giving them more time with their family, with their friends, like that's huge,
But you're right. It's a challenge, and I've never really thought about it like that. It's certainly nice to have a task and be able to fully accomplish it. And certainly I prefer the cases where we can completely eradicate a tumor, but as we know, that's not all of them.